Welcome to the Psychosocial Implications of New Modulators. This is the discipline group for social workers, psychologists, and psychiatrists at the North American CF Conference. I'm privileged to be one of your co-hosts. I'm Dr. Jamie Becker, and I'm co-hosting with Amy Mueller, and we welcome you to our session. We have no presenter disclosures other than we are both part of the Mental Health Advisory Committee for the Cystic Fibrosis Foundation, and we have both previously received and completed our cycles with the Mental Health Coordinator Grant. So Mental Health Coordinator Networking Session and Discussion Group is typically a very open forum, and in this forum we usually use it to bring together our community for discussion. We spend a lot of time here supporting and connecting with one another, doing a lot of problem solving about the frontline issues that are facing our patients and families today. This is a mental health community like no other. We're used to supporting each other. We're used to coming to the table and bringing together ideas and really having a collaborative discussion as part of this group. That's not happening this year. We understand this, we know it, but we're looking for ways to bring together the hot topics, the ones that are at the forefront of our community, and still remaining that open community that we love and we cherish in one another, and trying to find ways that we can really bring everybody's brains and everybody's thoughts together and tackle those hot topics. So in the past, we've brought topics like telebehavioral health, which allowed us to align and pivot really nicely into the COVID crisis, things like sustainability, and really this mental health grant altogether. This year, we're tackling new modulators, triple combination therapy, Trikafta, and really what that has done to our patient population and the families that we serve. So what we'd like to do is take this time and take these discussions and really move those to the places that we have the opportunity to have this networking and this discussion time happen. So our options this year are to use the chat, which is a live discussion that will be open for the next month or so. You can find those by following the directions that have been posted for the NACFC conference website, or you can use those avenues that are traditionally open to us, the social work listserv and the psych listserv. So what exactly is happening these days with mental health and triple combination therapies? Well, we know that we have a really exciting advancement here. We have something that is really changing and growing, and this has really hit our population in a huge way. This drug has changed the way that our patients and our family are viewing the world. And it's reaching a huge percentage of families. They are living better lives for a lot longer. At least that's what we're seeing right out the gates. We have families that have just had those overwhelming responses. They're posting those on social networks. They are getting that communication out there in the world, and they are happy and they are excited. There was a new lease on life as soon as Trikafta became available to the general population. Our patients are living, they're excited about this drug, and they're excited for the future. We're seeing that ripple effect going down into our younger patients who aren't yet getting this drug, but they're looking forward to it. And then on the flip side of that, we have some folks who we know that there are challenges that have come with the advancement of triple combination therapy. These are the things that we're seeing lead the discussions on our listservs and on our boards and in our clinics. We recognize that there's an entire group of moderate to poor responders who are really disappointed in the response that they've had to triple combination therapy. We're seeing side effects outweigh the results for some of our patients, where they are sometimes weighing the difference between having a physical impact, but having to outweigh their mental health impact and how that's been impacted by going on to this drug. Comparatively, the experiences that they're seeing on social media and what they're seeing be put out there is not necessarily that that individual is seeing happen for them, and that has really caused a disparate response in how people are cognitively processing their experience of this drug. Additionally, we do have a whole group of people who do not have access to this medication, and that in and of itself is super challenging. So for some of our folks, it's about the gene mutation. They simply don't qualify for Trikafta. For others of our patients, they're too young. They don't meet the qualifications. They have advanced liver disease. There are things happening that just means that they cannot have this medication. For other of our our patients with CF, they might live in a part of the world that doesn't have ready access to triple combination therapy. We're hearing from our colleagues in Canada and in Europe that the availability in market is not necessarily equal and available to every patient, even if they have the right genes and it should be available to them. It isn't necessarily accessible in the healthcare system that they are living in or in the drug available system that they're living in. So in shifting to the world that we're living in right now, we have COVID. That is a very real part of our lives. So when we factor in what happens when you have CF, plus you have mental health on the table, and then you add COVID to the mix, what does that look like? What has that meant for our patient population and for those of us that are managing their mental health symptoms as they do all of that? Well, the answer has been, it's been a little bit of a mixed bag. At the early part of this, we kind of thought our patients were doing all right. They were used to social isolation. They were used to doing things very virtually. For them, a lot of this was their norm to begin with. But then things started to extend for a while and things became harder. Now we're looking at a whole new world and we're not really sure where this is leaving our patients and our families. And I'm going to come back to this point because we have a little bit of data to share with you about this. But really, we have a lot of more questions about that combination of COVID plus mental health than we did before. But one thing we know about Trikafta is we have a lot of patients who are feeling really good, who are getting back to normal, and they just can't go anywhere, and they're frustrated with that. So clinically, on our listservs, in our consultation groups, these are the things that we're talking about. We have a perfect storm of mental health difficulties that are coming with the advancements of triple modulator therapies, plus we have COVID, plus we have all these things that are just kind of naturally happening in our universe, and it's really challenging. So mental health coordinators often will feel that our families are struggling, but we're not really sure how we can demonstrate that. Data is slow, research takes a long time, and we are not necessarily getting that information quickly. So in an effort to kind of fold some of this into what it is that we do have access and availability to, the CF Foundation was in the process of doing a mental health prioritization survey in an effort to ask our community, what is it that we should be focusing our mental health research on as we move forward into the next year and in years beyond? And in doing this, we kind of pivoted as COVID came up to ask some questions about COVID and the response to COVID in our community. So we solicited some community feedback on our mental health research topics, and we put that survey out from about the middle to end of July to the middle of August. And we asked this on Community Voice, social media, we asked this through care centers and on Genome, and we really were kind of broadly looking for CF patients and providers and caregivers to give us their responses. So as you can see, we had a nice response. We had 693 participants. About almost half were individuals living with cystic fibrosis. The other half were roughly parents, and then the other smattering were those caregivers, non-parents, spouses and partners, some immediate families, and we even had some participants who had lost a family member to cystic fibrosis. And these are what our results actually bore out for us. And when we asked the question, do you feel that the coronavirus pandemic has had an impact on your mental health? We had a pretty large N at 580 that responded to this question. And what we saw was actually that for both patients and parents, our mental health data is very high right now, that in that major and moderate impact, that our families are being disproportionately affected by the coronavirus. And so this isn't terribly surprising, since we know that even prior to COVID coming into the mix, if we looked at our mental health data and our mental health screening data, we already knew that our CF population was disproportionately impacted compared to the general population. But now that COVID is in place, we're looking at 60 to 70% of our population self-reporting that they feel that there is a moderate to major impact happening. Now you might ask, why are we looking at this in a session on triple modulator therapy? Well, if we break this down and we look at mental health by modulator status, what we actually found is that those individuals who are either eligible for a modulator and not taking it due to side effects or some other reason, or those who are simply not eligible at all, those individuals are even more disproportionately impacted and more likely to be in that major impact mental health category. So this just gives us a little bit of data about who is struggling in our community. And then on this other side, this other graph that you're looking at, although it's a very small sample size, so we have to recognize that, is that our most at-risk subset in population, those individuals who have already had a lung transplant, those individuals are also endorsing that they have had a major hit to their mental health at a much higher rate than we've seen before, or than we might have expected up to this point. So what we've pulled together for you today is an opportunity to begin discussions about triple combination and mental health, triple combination therapy and mental health. So we have experts from across the United States in both adult and pediatric healthcare. We're going to begin with Meg Hall, who's going to talk to us about the psychosocial impact on families and really those challenges that a lot of us are seeing in our clinics with the modulators and the folks who are really struggling with modulators. We'll move then to Carolyn Snell, who will talk to us about health-related quality of life and self-efficacy. Then on to Anna Georgiopoulos, who will present to us some of those cognitive and psychiatric symptoms that we're seeing bear out as we're rolling on to triple combination therapy. Mary Dell is going to talk to us about some of those psychosocial psychiatric considerations, including the mood and eating disorders that have been coming up a lot on our listservs. And then finally, my co-chair, Amy Mueller, is going to come back at the end and really tie together all of those themes, invite you all again to some questions and some thoughts that we have about discussions that we can continue to have, and offer up some resources about where you can find more information about Trikafta and mental health. Thank you so much for joining us, and we hope that you get a lot out of this session.
Hi everyone, my name is Meg Hall and I am the licensed clinical social worker at Maine Medical Partners and Maine Medical Center in Portland, Maine. And today I will be talking about the psychosocial implications of new modulators. This is for the discipline group 16, and I have no presenter disclosures, no relationships to disclose. We all know that modulators have provided an immense change of quality of life for many of our patients, and I have numerous stories of the ways in which patients have been positively impacted by using a modulator. Today we're going to be focusing a little bit more on some outline considerations and some other psychosocial considerations for families and patients who might not be at the forefront of our mind when we're speaking about modulators. We're going to talk about teenagers and how they're thinking about the future more than we may realize. We're going to talk about families and patients who may have decided against a modulator at this time or are still thinking about one and contemplating what that would mean for their family. And then we're also going to talk about patients and families who do not have access to modulators due to their child's rare genes, and also there's no available modulators for them at this time. So this does not include patients who do not meet the age requirements for currently available modulators. This is specifically for patients and families who, for whom there is no modulator at this time. So one of the things that I'd like to speak about first is just how the role of social work in CF and the role of other mental health providers may impact some of the psychosocial considerations when we're looking at modulator therapies. Often I think of social workers and mental health providers as being advocates, resource gurus, and many of us act also in a mental health coordinator role, and just speak about the general anxiety, depression, other emotional health issues that might be coming up for our patients. Perhaps being an advocate is one of the biggest areas in which our role is important when we're looking at this landscape of modulator therapy and the ways in which we can be advocates within the clinic environment by pulling together all of the patient's needs, stories, and psychosocial context. We can also be assistants in co-production of care and being patient-centered within our clinic environment. And we are also often tasked with advocacy within the larger medical institution that we might find ourselves in, or also really importantly at the government policy level where we may be advocating for affordable healthcare needs and bringing forth patients' voices, which is certainly something that we have found to be important as we're looking at modulator therapies. When it comes to being resource gurus, there certainly is room to provide support around copay and medication assistance, additional financial assistance needs that families might have, as well as thinking about future planning and school, college, and work needs that our patients might be facing. So when we think about teenagers, at least it's easy for me to think about teenagers as living more in the moment and not being as thoughtful about the future, and certainly maybe not as thoughtful as some of the adult patients I work with in terms of how modulators have changed their outlook on their lives and their decision-making process. I will say, though, that I've been proven wrong over the past few weeks in speaking with teenagers about modular therapy, and realizing that many of them are facing and charting a different future than they previously had with the positive changes that modulators have provided for them. They're thinking about their future more extensively. They're thinking about their future in ways that they previously hadn't allowed themselves to because they weren't sure what their future would hold with their health and their CF challenges. Of course, it's exciting to think about the future and to feel better and to have positive changes such as having a port taken out or having our G-tube removed. But it can also lead to feelings of anxiety and feeling both scared and excited at the same time. It is important for us to be checking with teenagers around these emotional health needs because even though they might be having major physical health improvements, they still might be struggling with some of these life tasks and decisions that we often associate more with our adult patients. And it's really important to understand that they too are going through some of these feelings of anxiety and feeling scared and excited all at once over the changing course of their lives. We also have considerations for families who are choosing to forego a modulator at this time. And this can be a very hard conversation for families and for CF teams. It's really important for families to be met where they're at and for the team to be open-minded and address questions, concerns, and challenges in a non-judgmental and open and safe manner. Families for whom modulators are things that they're not fully on board with may feel hesitant to bring this up in conversation with providers and may be struggling with how to frame this conversation, especially when they hear the positive benefits, but also have concerns over the modulators themselves. And again, super important to be very open-minded, provide a safe and open environment for them to be able to express their questions, concerns, and challenges. And this truly is where the multidisciplinary team is very important. The social worker or mental health provider may be tasked with helping with the emotional support or advocating for the family around what their questions and needs might be. The pharmacist might be working with the family on understanding and providing patient and family education around the medication. And providers might also be having those conversations around the benefits and the risks and all of the questions that families might have when it comes to that specific modulator. And then we also have considerations for families and patients who don't have access to a modulator at this time. These families might be experiencing mixed emotions. They may have worries about being left behind. And left behind can mean both in modulator development as well as in the potential landscape of CF care. This can mean families wondering what will happen to them if the CF landscape of care is changing as patients are getting healthier on modulators, but their children do not have access to those modulators. What does that mean for them? Will they be left behind in terms of treatment and copay assistance and just general protocols for CF care? This is something that's on their mind and is really important to know as we're working with those families who have all these different emotions and feelings and trying to support them in the best way we can. So what is the role of social workers and mental health providers when it comes to providing support to families with these considerations? We are often in the position of working with the family and within a broader context of view of strengths and challenges. That's just what we do as social workers and mental health providers. We provide a 360-degree view of strengths and challenges. We often can act as a liaison between the families and providers and the clinic team, and to help bring forth any concerns or challenges the families might be experiencing. Our roles of advocates are certainly very important in these situations in which we might be, sharing that it would be helpful for the family to be met where they're at, and to help the team understand that, yes, we may find that a modulator is an exceptional idea for a family, but they might not be there yet. And how can we engage with them to have the tough conversations and to have the conversations that will make the family feel most open and honest in communication? Again, there really is a role for multidisciplinary team members when facing psychosocial considerations and modulators. Pharmacists, providers, even nutrition, social work, mental health providers, there's a role for everyone to be pulling together and supporting the team, as well as patients and families, as we're looking at these complex needs that our patients might be feeling and experiencing. Certainly working as part of a team in times of these quote-unquote Zoom clinics can make a focus on communication even more important. I don't know how everyone else feels, but it certainly can feel that we're all more fragmented and we're all in our different spaces, socially distancing and not connecting in the face-to-face way we typically would. And so it's really important for us to be having conversations about what families might be experiencing and what questions that families might have, and to make sure that we're doing this in ways that are different than we typically would, whether it's having a phone conversation or bringing it up in one of our pre-clinic huddles, or having an email or in-basket message to our colleagues through our electronic medical record. Just really focusing on the communication side of things is super important given how we're all a bit disjointed right now. And then finally, patients and families really value the support of their mental health professionals. They really see us as a place for them to safely land, to have conversations about really hard things. And the psychosocial considerations of modulators can be very challenging. It can encompass the teenager that's feeling excited and scared. It can encompass the family that isn't quite sure how they feel about a modulator. And it can definitely encompass the families for whom there is not a modulator available at this time, and the different mixed emotions that they might be experiencing. I wanted just to point out again this advocacy slide, because I do really feel like this is where we are best able to support, or not one of the only areas, but we certainly are able to support our families with these special considerations, and being able to especially pull together all the patient's needs, stories, and in the psychosocial context of the patients and families. Really assisting in that co-production of care and being patient-centered, because all of these circumstances really are about being patient-centered and really listening to where the patients are at and providing them support in the most safe and non-judgmental space so that they can make the best decision for themselves. We also are looking at the advocacy at the government and policy level and making sure that those families for whom there isn't a modulator available at this time, that they still have focus on them, and that modulators continue to be an affordable option for families, and thinking about insurance coverage and thinking about access to care. These are all areas in which we really have a voice and can bring forth the patient's voices as well. And it's very important for our role to continue on in these areas as we're navigating this new landscape of modulator therapy. That's my presentation for today. I want to thank you all for participating and listening, and certainly if you have questions, feel free to hit me up at my email, and also you can network with me throughout the conference. Looking forward to connecting and hope that you have a great conference experience. Thank you so much.
Hello, my name is Carolyn Snell, and I'm a psychologist at Boston Children's Hospital. And I have the privilege today of being able to talk with you all about some research that we have done on health-related quality of life, optimism, and self-efficacy in people with CF who are beginning triple combination therapy. And this is, of course, part of a larger discipline group on psychosocial effects of TCT. And I am presenting along with psychiatry and social work colleagues about this topic. And for my part, hoping to add a combination of a couple of case studies that illustrate some themes that we have been seeing amongst people with CF in our center beginning this medication, and also to share some of our preliminary data for the purposes of really sparking discussion and discussing preliminary findings rather than drawing any particular conclusions at this point. And so in that spirit, whereas ideally we would be having this as a much more interactive session, since we're not able to do that, I really do welcome people to use the chat and use the networking platform to ask questions about this topic, and also share anything relevant from your center. I don't have much to disclose. We do receive a grant from the STRC, which is part of the Cystic Fibrosis Foundation, doing research on adherence. And so here I just wanted to display, this is poster number 578 that contains some of the data that I'll be sharing. And the reason that I display this is really to highlight some of the great people who are involved in this project, namely my social work colleagues, as well as research assistant and our pulmonologists and site leadership, as well as our broader center staff of dietitians and nurse practitioners and nurses and other multidisciplinary team members who have contributed to these efforts. So I begin by just setting the stage a little bit here that, you know, this of course was such a long anticipated drug release, and there was so much hope in the CF community and this huge response amongst the CF community, both at the national conference and of course in the virtual community as well. And we all began hearing, of course, these amazing patient stories of improved health and health-related quality of life, as well as people really feeling as though they had a new lease on life and a new hopefulness as their health improved as they started TCT. And really, you know, this was such an inspiring story of hard years of great research leading to a cure, and, you know, very much the story that we want to tell with medical research. And while that's all true, within that narrative, of course, we know as mental health providers that there's tremendous individual variability and complexity, both in terms of health outcomes, which some of my colleagues will speak to, and also in terms of mental health and emotional outcomes. And while people feel tremendous gratitude and hope, at the same time may feel a mix of emotions. And so I really want to be able to share their stories in order to illustrate some of those themes. And so this individual's name has been changed, but is actually someone who wanted his story shared. So we'll call this young man Owen. So this, and his story is really shared to illustrate some of the emotional reactions to starting TCT that we've seen amongst our patients, how those interface with the expectations that those patients had going into starting triple combination therapy. And then also I share this case to illustrate some of the longer term and more existential questions that some of our people with CF have been contending with as they start this powerful therapy. And so this is a 27-year-old male. He did have a pre-existing history of some anxiety and depression prior to starting TCT, and in general was just a very likable and empathetic person, but someone who, because of his illness, had really missed a lot of school and missed out on a lot of social opportunities, and was not achieving some of those developmental milestones because of his CF and some of the consequences of that. he had very high expectations for starting TCT, which he actually did on an inpatient basis with his girlfriend kind of present and involved. And he made this statement about, now I have a future, and he and his girlfriend have a future, and really saw this as, you know, his chance to build an adult life in this very strong way. And in fact, he did have a very positive response. He gained weight, and he started to think of himself as more of a healthy person, in the sense of being able to do things athletically that he didn't think he could do before. However, concurrent with this, he really was also reporting feeling tremendous pressure to all of a sudden catch up with all of his peers who may have been working towards longer term educational, relationship, or career goals that he had not yet been able to attain. And this was causing him a lot of anxiety and actually panic attacks. And so he was in therapy for this, and he was prescribed an SSRI by our team. And the incident that I want to share is, he was training for this new job. He was very excited about it, you know, stable, working for the city, a career trajectory for him. And he unfortunately had a panic attack on his second day of job training. He was doing this task while others looked on, and he didn't think he was doing it right, and got embarrassed and then panicked. Unfortunately, an ambulance was called, and while he was medically cleared and went home, he was understandably embarrassed by this. And he was able to talk about it after the fact, you know, willing to talk about skills he could use the next time, get ready to go, said he wanted to redo that day of training, and then still felt frozen. And really, on the debrief after the second time that he wasn't able to complete it, he said, I really just couldn't get out of my head, and really was thinking about all of these longer term and pressured goals that he had for himself. It also came to light that he was not taking the SSRI until the morning of the first training day, and so that could have also, of course, been a factor. There is a positive resolution to the story, however, which is why Owen wanted his story shared, which is that he's now starting a new job, moved into an apartment with his girlfriend, and is now taking the SSRI, which he reports is tremendously helpful, and is still in therapy. And, you know, really realized that he realized that change is a process, that this is going to take time for him, and that this idea that positive stressors are still stressors, right? That this is still going to take some time for him to realize what this new state of health is going to mean for him and his goals, and to then work towards those things. On the positive side, this also was really an opportunity for personal growth for this individual, to realize that it's okay to ask for help and okay to take things at his pace. He wanted to share this story with others, and I share it because we can miss real suffering in people if we don't ask. That beneath this surface of gratitude can often lie some anxiety for patients, and some adaptation. And in order to get at those things in a 30-minute clinic visit can really require taking the time to ask some questions that we may not always think to do. The second case study that I wanted to share is also really a story of a combination of gratitude and stress, in this case related to body image concerns, which we have seen in many of our adults and adolescents who are starting triple combination therapy. This case study is actually an amalgam of a couple of individuals, and I'm titling it, "I'm So Grateful, But It's Been Hard," as a direct quote by one of them. And so this is Chloe. She is a 20-year-old college student, very high achieving, articulate, put together young lady whose CF had mostly manifested in GI concerns, and she had had a G-tube with fewer respiratory manifestations. There were some signs along the way that Chloe had some, anxiety and stress related to body image. She had wanted her G-tube removed, but then wasn't able to maintain a healthy weight without it, which was a setback, and then gained some weight with reinitiating use of the G-tube. And then subsequently, her mother expressed some concern about not taking enzymes and perhaps doing this in order to lose weight and to return to the pre-G-tube usage weight. And so when Chloe started Trikafta, she had great results, gained weight, no longer needed to be using her tube, but as we might have predicted, struggled somewhat with the weight gain that she experienced on this new medication. She Also used this as an opportunity for some insight and personal growth, as did Owen. And because of having these concerns and recognizing some increase in unhealthy eating patterns in herself after the TCT start, Chloe restarted therapy while at home with family during the pandemic and really said, you know, she wanted to work on her body image and accept her new, healthier self. And she really took more of a focus on strength and fitness after that point. Reached out to family for support around this, and was able to look back and realize how her body image had been distorted before in ways that she had not fully recognized prior to starting TCT. And, you know, of course, I chose this story because weight and body image are such important issues to ask about, perhaps particularly for our young female patients starting TCT, although we do hope to have some more data on the impacts on body image across different age ranges and for both genders. And but really just wanting to highlight the point that it's not easy for people to give up being effortlessly thin, which has often been the case for many of our people with CF before initiating triple combination therapy. So I now wanted to share some data that we have, preliminary data on quality of life and mental health. This is a study that we did for people with CF 14 years of age and older who are followed at our combined pediatric and adult CF center here in Boston. And we're really sharing data from the first of these two time points. The first time point, which we are terming baseline, is actually within 6 months of initiating triple combination therapy. Of course, we're not ready to go with a study and an IRB approval the day that that TCT was approved, since we didn't know when that was coming, and so and had some delays with the pandemic, and so ultimately our baseline occurred within 6 months of TCT start, and then we had time points at 3, 6, and 12 months. And we'll share data from the baseline and 3-month time points today. We chose our measures with a number of things in mind. We did want to choose measures that had been used in prior research with people with CF. We also, of course, we're looking at what we expect to change based on clinical and research knowledge. And we also wanted to look at variables that we thought were things that could be influenced, and we're thinking forward towards the perspective of resiliency research and perhaps positive psychology interventions, as I'll discuss a little bit at the end. And so these were the measures that we ended up with. We were measuring health-related quality of life using the Cystic Fibrosis Questionnaire Revised. That was our primary outcome measure. And we also, for this particular data that I'll be sharing today, measured optimism as well as self-efficacy. We included also some open-ended questions, gathering qualitative data. And we were fortunate enough to be able to add a 3-month time point as a supplement to be able to look at the widespread mental health impact of COVID-19 on our population, as well as to be able to look somewhat specifically at anxiety associated with coronavirus. Our baseline surveys, it's worth noting, occurred in April of 2020, and the 3-month surveys in approximately July of 2020. It depended on exactly when people started. But I mentioned these time points because these were different experiences of the pandemic, whereas in April, we were in the midst of lockdown here in New England. By 3 months in July, things were more open commercially across the state, and yet some people with CF were still not doing all of those activities yet due to infection control concerns. So we enrolled 65, yes, exactly 65 adults and adolescents with CF in the study, and about 2/3 of those completed the 3-month time point. As you can see, most of our participants were adults, and we had somewhat more females than males, with 2% self-identifying as non-binary in our sample. And we had a relatively educated group here in Boston with over 45% completing college or above in terms of education. Here are some of our preliminary data from baseline and 3 months. As you will see, if you compare baseline data to a large 2010 sample of data gathered by Quittner and colleagues, What you see comparing those blue bars to the green is that across the physical, respiratory, emotional, and social domains, there were statistically significant differences between our baseline TCT start data and 2010. And so we saw higher physical and respiratory functioning, but lower emotional and social functioning comparing baseline to 2010. At 3 months, comparing the blue bars to the red, what we actually saw was a reported lower quality of life than baseline for the physical, emotional, and social domains. And of course, the question is, why would that be? And I'll speak about that a little bit when we get to conclusions. Another thing we found is that in general, we had a moderately optimistic group who also had a moderate sense of self-efficacy. It's worth noting here that what we mean by self-efficacy, just so we're all speaking the same language, is judgment of how well one can act as needed to deal with situations in the future. And so one can imagine that unpredictability of things like the pandemic and of unpredictability of outcome with TCT start could perhaps impact one's self-efficacy, but it comes from the theory of motivation. And so what we're seeing is, in general, not specifically related to TCT, moderate optimism and self-efficacy, and not a lot of changes from 3 months, slightly lower self-efficacy, but no statistically significant change in optimism. We also, as I said before, had the opportunity to look at some data specific to the mental health impact of coronavirus at 3 months. And what we were able to see is that most people were not falling within the clinical range on a validated measure of anxiety specifically related to COVID-19. We used a 5-item measure that had been developed, and that measure assessed anxiety, panic, and somatization directly related to the pandemic. Interestingly, we not only did not find clinical levels of anxiety by the 3-month time point amongst our people with CF, we also did not find that their level of COVID-related anxiety was correlated significantly with other measures of quality of life and mental health. So they, in general, reported some, but not pathological levels of anxiety, specifically related to COVID, such as anxiety related to getting sick. With the open-ended questions, a couple important things to note include the degree of individual variability in responses, which we also saw in our case study 1. Also, people seemed to have some fear of being disappointed in their outcomes and consistently reported some changes in future planning in response to starting TCT, just as we saw in Owen's case study 1. There was also concern about side effects amongst many individuals, which my medical and psychiatry colleagues in this discipline group will be addressing. So in order to sum up the study findings, in general, people who were starting TCT reported moderate optimism and self-efficacy. They reported better physical and respiratory functioning, but worse emotional and social functioning than a 2010 sample, possibly better respiratory and physical because of TCT, and worse emotional and social because of the social isolation of the pandemic. And that is in part my hypothesis. But obviously we need to gather more data in order to further illustrate this effect. One thing that is worthy of noting is that participants did not generally report high levels of COVID-related anxiety, and therefore it does not seem as though that alone can explain, particularly since it's not correlated with other variables, some of the data that we're seeing in terms of people's emotional and physical quality of life outcomes related to Trikafta start. And what we saw in July was a decline in emotional and social quality of life, and less change in physical and respiratory domains. We will be looking at some body image related data, which may further flesh out the themes of case study 2 once we have more complete data at the 6-month and 12-month time points, since the 3-month time point was a partial time point. And finally, just some overall conclusions. So many people who start TCT are experiencing these wonderful life-changing results in terms of their health, and yet this is not without complexity and individual variation. There's often anxiety underlying some of the gratitude that we hear from our patients, and they are still experiencing the stress of changing their expectations and their views of themselves, and perhaps their reference group of who they are comparing themselves to as they start TCT. And this really illustrates the idea that positive stressors are still stressors. There are also opportunities for growth, as we saw in some of the great resilience and insight of the two people in the case studies as well, in response to some of these changes that they're adapting to. So one question that this raises, of course, is, are our patients healthier but not necessarily happier right now as they adjust to these changes and as they also go through the pandemic experience, of course, which is impossible to entirely tease apart. And the questions that this really raises for me are, how can we work best with our patients and families to set expectations that are realistic and also hopeful? We want that moderate optimism, and yet we also want some realism with respect to some of the emotional impacts and physical impacts of TCT start across different individuals. And as providers, what we can do is really to ask open-ended questions, normalize our patients' mixed feelings and the variability of their experiences, and really work with our patients to help foster their resilience in the face of this really major change in their quality of life, so that we can maximize their quality of life and mental health to the extent possible.
I'd like to thank the organizers for inviting me to participate. I'm Anna Georgiopoulos. I'm the psychiatrist for the Mass General Hospital Cystic Fibrosis Program. And this is my disclosure. So today I'm going to focus on CFTR modulators and psychiatric symptoms, specifically Trikafta, and to talk about the temporal association of modulator initiation and psychiatric worsening. So first of all, what is it that we're observing? How do we understand these observations? And then how might we manage these symptoms in the face of limited evidence? So what do we observe? Well, there's limited evidence. There's a systematic review that does not show significant neuropsychiatric symptoms in the top 15 adverse events in clinical trials of any of the modulators, with the exception of fatigue. And then if you look at the Trikafta prescribing information, dizziness is the only neuropsychiatric adverse event that is relatively common. However, there are a number of case reports and case series in the literature starting to accumulate, only one so far with Trikafta. And so we're left with clinical experience, listserv anecdotes, and blogs. And if we look at that kind of anecdotal evidence, we notice that a variety of changes have been described after people start on Trikafta. So one is changes in mood, in some cases improved mood, but in other cases depressed mood, mania, or mood swings. Changes in level of anxiety, up or down, changes in interest, energy, and motivation, changes in sleep patterns, including insomnia or vivid dreams, changes in thinking and concentration, such as brain fog, word finding, or memory concerns, and perceptual changes, such as hallucinations or intense sensory experiences. So how do we understand these observations? Well, I'm using a framework here from our paper in Psychosomatics from a few years ago. And this still would apply to any of the new modulators as they emerge. So the first hypothesis could be that this could be unrelated. Common things are common, psychiatric symptoms are common in general and in people with cystic fibrosis, so sometimes this could be a coincidence. The second is that there could be a psychological impact of starting modulators, and other speakers are spending quite a bit of time today talking about the complex meanings of starting a highly effective modulator. The third is a direct effect of modulator treatment, and the fourth could be drug-drug interactions. And I'll spend most of my time on these hypotheses 3 and 4, direct effects or drug-drug interactions. So why might there be a direct effect of Trikafta on neuropsychiatric symptoms? Well, could it be through the mechanism of action due to CFTR expression in neural cells? There are studies showing that that CFTR is expressed in the brain, and we don't know the impact of that expression in the fetal brain and throughout development, and then we don't know what happens when that's changed with a modulator. Another possibility for a direct effect of Trikafta could be some sort of adverse event that's unrelated to the mechanism of action. So it doesn't have to do with modulating CFTR, but it has to do with a different effect of one or more of the components of triple therapy. So in this case, this is an example with ivacaftor. We do know that ivacaftor shows significant affinity to a variety of receptors and transporters that are found in the brain, including serotonin, dopamine, delta opioid receptors, and similar for some of the ivacaftor metabolites. And in this study, Schneider and colleagues created some mouse models, or used some mouse models that are typically used for depression and anxiety. One is immobility in forced swim, so whether mice get hopeless when they're in a situation where it looks like they can't get out of a difficult situation. And the second for anxiety would be how much they tend to explore or travel in an open field. And in this study, when they compared ivacaftor to fluoxetine and to ketamine, they actually found that ivacaftor showed at least as much benefit for depression and anxiety symptoms as modeled in mice. And they also reported a study in 23 people with CF noting improvements in anxiety on the OSSCOR CF, which is a quality of life measure. So another hypothesis could be drug-drug interactions with Trikafta. So with Orkambi, we were worried about interactions because lumacaftor is a strong CYP3A4 inducer, and so it would decrease the levels of citalopram, escitalopram, and sertraline. But that's not the case for Trikafta, which doesn't contain lumacaftor. And in fact, we have the opposite problem with Trikafta, where strong inducers would actually reduce the level of Trikafta, especially through reducing ivacaftor levels. So we want to be careful to avoid using carbamazepine or St. John's wort, which is available over the counter and often used for mild to moderate depression for people who are taking Trikafta, because it may make the Trikafta less effective. However, Trikafta does actually increase, not decrease, the exposure to medications which are sensitive P-glycoprotein substrates, again through ivacaftor's impact. So this is something that potentially could be clinically significant for escitalopram, which is one of the main SSRIs that's recommended by the depression and anxiety guidelines, and possibly for other psychotropics as well. And there may be other transporters that are inhibited as well through elexacaftor. And so all of this is an understudied area which remains to be elucidated. So how might we manage psychiatric symptoms that occur at the same time that someone's starting Trikafta? Well, I'm going to go through a few different examples of different scenarios. So in this example, there's actually a benefit for mood and anxiety, so no intervention is needed. So an adult with CF who has a history of depression and anxiety, usually the depression is worse at the time of CF exacerbations. Usually the anxiety gets worse and panic episodes get worse when there's hemoptysis. They've been stabilized, taking an SSRI and a benzodiazepine as needed for panic. So this person starts Trikafta and immediately feels much better in terms of energy levels, stamina, cough, quality of life, functioning. They're not having as many episodes of hemoptysis, so they're not panicking, less anxious, and they're enjoying life. Their mood is really good. And then, so this seems really positive, but one of the things to consider is sometimes there are gaps in availability of medication for a variety of reasons. So in this case, the person has an immediate relapse of both pulmonary symptoms, physical symptoms, and also mood and anxiety symptoms. However, when they again have access to Trikafta, they have a quick recovery. So this would be a situation where it's important to, if you're noticing a relapse in mood and anxiety, to find out what's going on with availability or adherence to medication. But no other intervention might be required. So here's another example where there's depression and anxiety, and the usual interventions that we would think of end up being effective. So in this situation, we have an adult with CF who has depression and anxiety and ADHD. They're able to manage those symptoms well with an SSRI along with bupropion XL. And then they start Trikafta. Their FEV1 goes up significantly. They're feeling good physically. However, they start to notice worsening mood, anxiety, apathy, new concerns with trouble finding words or with memory, and also a new onset of insomnia and very vivid, disturbing dreams. So in this case, an increase in the SSRI and the Wellbutrin, the bupropion, is effective to improve the depression and anxiety. A stimulant is tolerable and has a good response for the ADHD symptoms, although there are still some word finding and memory concerns and vivid dreams. And they're able to accommodate to those and kind of get used to them over time. Insomnia also improves over time, and this way this individual is able to continue taking Trikafta and continue with the physical benefits of the highly effective modulator. Now, this is a case report from the literature, a new report in Psychosomatics. Tyndall and colleagues described the case of a 19-year-old woman who had no prior treatment with modulators. She had a history of generalized and social anxiety, major depression, but no history of suicidal thoughts or behaviors or self-harm. She had a history of ADHD, and she had a history of 3 prior episodes of sleep paralysis, but nothing currently, and also a family history of schizophrenia. So this young woman started Trikafta, and at the same time started some quetiapine or Seroquel for insomnia. And 2 weeks later, her FEV1 is up quite a bit, from 60% to 83%. However, her mood is starting to worsen. She's having passive suicidal ideation. And then at 3 weeks, she's having sleep paralysis and hypnopompic hallucinations. So sleep-related hallucinations of a man sitting on her chest, which was very frightening. So what's going on here? You know, if we think about what we saw earlier in terms of some of the mechanisms of action at play with Trikafta, the serotonin 2C receptor should be helping mood in terms of the ivacaftor ingredient, but could the 2A receptor activity be worsening visual hallucinations? So this was a speculation that Tyndall and colleagues had. And so what they decided to do was to discontinue Trikafta and see how things went. And so there had been several days of the sleep paralysis and hallucinations. This ended after 2 days of stopping Trikafta, but the depression continued. So they started some sertraline and clonazepam for anxiety as needed. And things were okay until this young woman was hospitalized for a pulmonary exacerbation a month later, and now her FEV1 is down below her baseline to 51%. So what should we do now? And I wish we were in person so we could have a nice discussion about what we might do in this situation. But I'm going to show you what this group did. The psychiatric consultants in the hospital recommended restarting Trikafta in an off-label manner with a gradual increase in the dose. So typically, the usual dose is, well, first of all, there are 2 different tablets that constitute Trikafta. So one is a triple therapy tablet that has elexacaftor 100 milligrams, tezacaftor 50 milligrams, and ivacaftor 75 milligrams. And adults or adolescents 12 and up would take 2 of those tablets in the morning. And then the evening pill is contains only ivacaftor 150 milligram tablet, and the person with CF would take 1 of those every night. So instead, the recommendation was to start with 1 of the triple therapy tablets in the morning. And after 5 days, this young woman with CF noticed worsening depression, so they increased her sertraline to 50 milligrams. And then she went up to 1.5 of the triple tablets and 1.5 of the plain ivacaftor tablets, but took them all in the morning. Presumably that decision might have been to try to help with sleep, thinking it would wear off by nighttime. They don't specify that in their report. And she noted some increased anxiety and panic, although this improved gradually over time. There was a trial of bupropion that didn't go well, and that was discontinued. So by 2 weeks after hospital discharge, she was taking 2 of the triple therapy tablets in the morning, and she was back to full dose of everything at 4 weeks, and her FEV1 had recovered pretty well, up to 69%. And things went well until that full dose was resumed, and then she started having sleep paralysis and hallucinations again, and started having suicidal ideation again. So they went back down on the dose of Trikafta, increased the sertraline, increased the quetiapine, and increased the clonazepam. And unfortunately, at the time of publication, the depression and anxiety were continuing, the sleep paralysis and hallucinations were continuing, and it was unclear what the solution was going to be. And the suggestion was to monitor people closely when starting Trikafta. And in this case, going back for a moment to the previous slide, remember she did have a history of anxiety, depression, ADHD, and sleep paralysis, plus a family history of schizophrenia. And we saw earlier that one of the impacts of ivacaftor could be related to the dopamine transporter, which may be relevant for symptoms of schizophrenia. So the hallucinations, she may be vulnerable in a particular way to these hallucinations that maybe someone else might not be. But it's important to be aware of these possibilities. And it's also notable, her quetiapine dose was not particularly high, but on the other hand, it didn't seem to eliminate this problem like we might hope it would in someone with psychosis due to another cause. And again, these are episodes of visual hallucinations related to sleep paralysis, which may be a different kind of thing. And the speculation was this wasn't a dopamine related impact, but maybe related to one of the serotonin receptors. Okay, so I'm going to talk about another couple of cases where there's some complicated decision making, and I'd like to thank the individuals with CF who kindly gave permission to share their stories to try to help others, help us all try to make sense of how to manage these situations. Okay, so in this case, there was a need for intervention for the new onset of mania after starting Trikafta. So this is a woman in her 60s with no prior use of modulators. She has a history of strictly unipolar depression and anxiety, so no history of mania. And she's been doing well taking escitalopram or Lexapro 10 milligrams per day and melatonin here and there for insomnia. And she had felt that that 20 milligrams of escitalopram was too much for her. She was treated in the community, and she had self-reduced that for the last several months and had been stable with the 10 milligrams. So she started Trikafta and had a nice increase in her FEV1. And then she started to notice word finding problems. And then at about 2 weeks, she started to have severe mood swings. She also noted unrestorative sleep and vivid dreams. So what were the symptoms of mania that she experienced? She had a happy mood. She said she felt almost grandiose regarding, now that her CF had improved, all the things that she was going to start to do. She was constantly thinking. She was more talkative, more social. She was more distractible. She was bouncing from subject to subject, couldn't read. It wasn't easy to follow TV shows because her attention was impaired. And she said she felt extremely agitated. She was easily angered. She would scream at other people. Even while this was happening, she had full insight that this was not her, but she didn't feel any sense of control over the irritability. At the same time, she had worsening depressive symptoms. So she was experiencing extreme anxiety accompanied by mood lability. So she felt like these were minute by minute highs and lows, and the downs were worsening in addition to these elevated moods. In the past, she'd had, when she was depressed, she might have had fleeting suicidal thoughts, but now she was having intense suicidal thoughts throughout the day. And she really felt that she was in an impossible bind. So this mixed state that she was in other words, a combination of mania and depression, was really the worst experience of her life. And she felt sure that the Trikafta was causing these mood swings, but she said, if I can't take it, I don't want to be here anymore. It was so important to her to be able to experience the benefits that she also was having from a physical standpoint. So what was the intervention? So about 4 weeks after starting Trikafta, she made the decision to reduce her escitalopram from 10 milligrams to 5 milligrams. And a week later was not yet having any relief. And she, on the advice of the CF team, stopped her Trikafta at 5 weeks after starting, and the mania and suicidality resolved. So cautiously, there was a trial of restarting Trikafta, and similar to the Tyndall case, it was done in a graduated way. So she started with 2 of the triple tablets in the morning, 3 days a week, about a month after having discontinued, and then went up to using it daily. And she felt like she was having similar benefit both for her pulmonary and GI symptoms, but did not go back to taking the evening ivacaftor tablets. And subsequently, we increased her escitalopram to 7.5 milligrams, which seemed to help with the remaining fogginess and trouble thinking of words without bringing on any additional mania. So again, it may be that if the ivacaftor is a bit of the culprit in the serotonergic effects, we know that people can have a manic response to antidepressant doses being too high. It may be that she was really just not able to tolerate that much ivacaftor along with the escitalopram, and she was able to tolerate a lower dose of escitalopram without the evening ivacaftor tablets. Okay, and here's another case. This will be the last case that I talk about today. This is a woman with CF in her 40s. She's tried Orkambi and Symdeko in the past with some benefit, but no serious adverse events. And she has a very minimal past psychiatric history. She's used alprazolam when she was worrying at night at various points in her 20s, used it pretty sparingly, minimal counseling in the remote past. But she did have an extended family history of bipolar disorder. So I'm listing the time course here because, as we know, we're in the middle of a pandemic right now, and some people had the experience of starting highly effective triple therapy in clinical trials, and so there wasn't the confounder of the COVID pandemic. But in this case, there was. She started in February. She had great physical benefits, but then in April started to notice her sleep was worsening. She had new insomnia. Normally she would sleep 12 hours a night and able to nap well. Now she was only sleeping 4 hours per night. She said her mood felt definitely depressed. She was crying, but she also noted quick mood switches from good to then sad to irritable and dysphoric, and a high anxiety that was of a different quality than her times she had worried in the past. So she felt revved up, she felt jumpy, she was startling easily, and her thoughts felt spun up more, although she wasn't talking fast or looking sped up to others. She was surprised to feel a sense of high energy, even though she was getting less sleep. So this looks like a decreased need for sleep. She should be tired, but she can't nap anymore. And she also noticed an increased libido, although no impulsive or reckless behavior, which is not something we would expect with someone who was depressed. Also in April, she started to notice cognitive symptoms. She felt in a fog. That word seems to come up quite a bit, brain fog or fogginess. She noted poor memory, trouble retrieving words, circumlocution. So saying to someone, you know what I mean, and they don't know what she means. And feeling like she usually was very organized and on top of things, but was having trouble with starting things, follow through, not feeling motivated, which to her felt more cognitive than mood related. And then in June, she started to experience some body image symptoms for the first time in her life after having some comments from others about gaining really a modest amount of weight with Trikafta. She also noted some sensory symptoms. She said sounds sounded too loud, things seemed too bright, and some intensification of taste as well. And remembering that all of this is happening in the context of our depression and anxiety guidelines. Her GAD-7 screening score was 17, so in the severe range. PHQ-9 was 8, so in the mild range with no suicidality. We did an ADHD rating scale, even though she had no prior history of ADHD, which would mean that she wouldn't be diagnosed with ADHD itself, but just to get a sense of the severity of her attentional symptoms. And she was in the moderate range there. And she said the impairment was very difficult, particularly the fogginess, the anxiety, the sleep problems, and just not getting things done in the way she typically would. So the intervention here, first of all, she had already realized that it made sense to moderate her initial response to COVID-19 and rather than trying to clean every single thing that came into the house, to focus on major precautions that were important to take care of herself and her family. She stopped her her evening ivacaftor tablets in August, but there was no benefit to her mood changes at that point. And she was really concerned about the possibility of further decreasing the dose or of stopping Trikafta to see if things would improve. She did not want to lose the benefit, and she preferred to a psychotropic medication trial. So in considering what to do, although her screening scores look like, this is primarily anxiety with maybe some mild depression, we talked about these kind of hypomanic features to her mood and anxiety symptoms. Just going back a slide a minute, remember she's having these quick mood switches. She has a decreased need for sleep. She feels like the anxiety is not just her typical worry, but she's revved up. Her thoughts are spun up. She's having an increased libido, increased energy. So for those reasons, and in the context of a family history of bipolar disorder, and also she has used linezolid during exacerbations in the past, although not needing them since starting Trikafta. So that argued against starting with an SSRI, which is typically first line for anxiety in this case, and rather starting with clonazepam at night. So to put things all together, evaluation and management of psychiatric symptoms with triple therapy is challenging because we have minimal evidence for these associations or for what kinds of interventions are going to be effective. There are a lot of confounding factors. It looks like people who have some prior psychiatric vulnerability, whether personal or family history, may be more at risk, but that also makes it more difficult to tell what's causing what. There are, of course, everyone has personal stressors, which sometimes make it hard to sort out what's triggered an exacerbation of mood or anxiety. And then we're in a unique time where people are adapting to COVID-19, and that is certainly causing some mood lability, sleep problems, brain fog, and all kinds of other things. And also that that sometimes there are other medications involved which we have to account for. So it does make sense, it seems, to monitor people closely before and after starting Trikafta, and to ask people what their experiences are, because these seem to vary quite a bit, and people may not volunteer some of the symptoms that they're experiencing unless you dig in a little further. So if someone says they're depressed, make sure to ask about manic symptoms, anxiety, sleep, cognitive symptoms, to do a really careful assessment and differential diagnosis. And then there'll be a range of interventions to consider. In some cases, mood and anxiety are the same or actually have improved, and we don't need to do anything. And this is how we hope it goes most of the time. In some cases, a psychosocial support may be adequate, or psychological interventions for mood or anxiety, or for cognitive remediation, dealing with memory concerns or things like that. And in general, for psychopharmacologic treatments, we're going to look at the symptoms in front of us and try to treat them the best way we would know how, in case of other causes of these symptoms. And hopefully over time we'll learn more about what works best. And then the other possibility is to adjust the dose of Trikafta or discontinue Trikafta, but that of course risks the loss of benefit for the other CF symptoms. So it can put people in a bind, but it's important to that different people will make different decisions about what's most important to them and how to address it. So it really does require collaborative treatment planning with the individual with CF, family, treatment team, and in many cases, mental health coordinator, psychologist, and psychiatric consultant. Thank you so much. Appreciate your attention.
Hello, I am Mary Lynn Dell. I am at Children's Hospital New Orleans, and I'm most pleased to be able to participate in this seminar on psychosocial considerations of Trikafta. In terms of disclosures, I have publishing contracts with the American Psychiatric Press and Oxford University Press, but no significant or even insignificant conflicts with the medication. The outline of my talk, I will be talking about a general approach, mood, anxiety, irritability, developmental considerations and developmental disorders, body image, disordered eating, considerations in the pediatric age group, and recommendation based on my clinical experience. In fact, the bulk of this talk is about my own clinical experience treating individuals on the triple modulator across the lifespan. My general approach to psychiatric concerns of patients both before and after starting elixacaftor, tezacaftor, and ivacaftor therapy are as follows. There is a pulmonary, GI, medical, other evidence base, and that includes pathophysiology of cystic fibrosis, the treatment, standards of care, potential medication interactions and side effects, and the benefits of treatment. In addition, we know that there is a psychiatric or psychosocial evidence base or considerations that we need to consider for good care. That includes diagnostic criteria for disorders, causes and exacerbating factors, social determinants, screening recommendations and instruments, as well as treatment modalities. In addition, I cannot underscore the importance of the multidisciplinary team approach to treatment. It's important to address multiple aspects of care and notice different concerns from multiple perspectives, and to have multiple touch points with patients and their families over time and in different treatment settings. In addition to the manifestation and severity of specific symptoms, the appearance or the change of symptoms over time may be more significant than the actual severity of the symptom. And what I mean by that is that even though the snapshot of psychiatric symptoms in some respects may not be as severe as what some other patients we may treat may be experiencing, for any child, for any adult with CF, and for their significant others, a lot of times it's the change as opposed to just the symptoms themselves, the change in symptoms, severity, life, and the affectations of their lives, how it's embodied in their lives, that presents the challenges or the concerns. Some important questions. Who's reporting the concern? Is it the patient, the parent or the caregiver, the medical provider, the significant other, or a combination of all of these? What's the nature of the concern? So what I call internalizing, meaning subjective feelings of depression and anxiety, or is it externalizing, such as irritability, aggression? What is the baseline psychiatric status and level of functioning of the identified patient and the significant people in hers or his CF care and life? Now, then there's the potential relationship of the psychiatric concerns to the modulator. Sometimes symptoms can be a cause and effect of the medication. It's always possible that there are drug interactions or drug-drug interactions. And then we need to consider the improvement in health and well-being due to the drug, whether you're talking about medical symptoms or emotional symptoms or expressions. Is the patient familiar with those or not? For instance, if one is not used to being well, then even a positive change can render concerns. It's what I've sometimes heard referred to as Newton meets Trikafta, meaning that even as there are positive changes in the person's life due to the triple modulator, that means that the rest of life has to adjust to meet or to be compatible with those changes. And some of those other adjustments are what become stressful or contribute to psychiatric concerns, as opposed to just the simple relationship, cause, effect, or otherwise, of the triple modulator. And then, of course, the expression of mood, anxiety, other psychiatric concerns can be totally unrelated to any medication. Above and beyond, most of all, I think I've learned that humility is really the prime virtue in this endeavor. There are few to no triple modulator studies of mental health effects available at this time. Only 3 or so case reports, and Dr. Georgiopoulos will be discussing those. We know little about the effects of the modulators on brain tissue and neurotransmitters, whether they're at the gross cellular level or intracellularly. And we need to continue the regular mood and anxiety screenings with trusted and reliable tools, though it's unclear how the modulator will influence measures used and the timing of future screenings, if at all, or let's say the optimal timing, the intervals that will provide the best information to us so that we can continue to assist our families and the identified patients in an optimal fashion. Now, I have only been in Louisiana for approximately 2 months. For the past 8 years, I was privileged to work with what I believe is arguably the top team in the country at Nationwide Children's Hospital and the CF Center at Ohio State and in Columbus, Ohio. And I commend poster 584 to you, the effects of highly effective modulator therapy on mental health measures in patients with cystic fibrosis. This is a prospective study, and everything that I'm going to mention is on the poster, so it's there for you to view and become familiar with. But I'm going to give you an idea of some of the things that this study is looking at and what's being followed and why, and what I then, as the psychiatrist on the team for 8 years, seeing patients, working with families, parents, spouses, significant others across the lifespan and across the full continuum of care, from diagnosis to outpatient to inpatient hospitalizations to ICU care, what our experience, or at least my experience as a psychiatrist, has been. So what poster 584 explains is a prospective study with measures administered at time of drug initiation, then at 1, 3, 6, 9, every 3 months for a year, then every 6 months, and then once a year toward the end of the study. Measures given are PHQ-9, GAD-7, Snyder-Hope scales, CFQR, PROMIS depression, and PROMIS anxiety scales. And then the patient groups have been stratified by illness severity, including it included compassionate use, expanded access, and then most recently has been expanded to those who have joined after FDA approval for triple modulator therapy. As of June 2020, there were 167 total enrolled with an age range of approximately 15 to 46. The less severe disease groupings tended to have average younger ages. The findings as analyzed to date are that on the PHQ-9 and GAD-7, there was a decrease from baseline at 1 and 3 months, but the PHQ-9 was the only thing of those two that remained significant at 6 months. PROMIS depression and anxiety both showed decrease at 1 month for adults, but not 3 and 6 months. The CFQR for ages 14 and above, there was a statistically significant increase in domains at 1 month. At the 3 month mark, the physical vitality, treatment burden, health perception, body weight, and respiratory those changes remained significant, but not emotion, eating, social, and digestion. And then at the 6 month mark, changes from baseline remain significant for all domains except eat, roll, and digestion. Also, we've included the Snyder-Hope scales in this, attempting to pick up on that dimension of what are patients thinking, what are they planning, their level of optimism, and their own internal thought processes as they're on this medication that can indeed be life-changing, and more to come in the future on all of that. So anyway, that, to my knowledge, is really the only prospective data that there is out there. And so in terms of depression and anxiety, yes, there is some indication that at least early on, there is a little bit of improvement, at least in anxiety and depression. Now, what follows, because we did have such limited data, are my clinical impressions generalized here for discussion that, again, that I have noted in the patients that I've seen. Also, it's important to realize that there is no way that one psychiatrist can see regularly over 500 lives in a program. And certainly, too, the patients that I've gotten to know the best are the ones with who have had significant symptoms enough to warrant referral to a psychiatrist above and beyond the supportive care that they've received from their pulmonary physicians, from their dietitians, from social workers who have known them since birth in many cases, and then also from our two great mental health coordinators. So overall, the mood in adult patients, and again, I do see patients over the lifespan. I was struck by the fact that there has been some improvement in depressive symptoms, but it has tended to follow the improvement in CF symptoms in general due to the modulator therapy. I generally continued antidepressants at the same doses, though some individuals did request a decrease or discontinuation of their psychotropic medication, especially antidepressants, after a few months of feeling better physically. If depressive symptoms did not improve or did not improve significantly, there tended to be an intercurrent psychosocial event or stress during that time period. Examples being a death of a parent, broken engagement, perhaps losing a job. I tend to be very kind of conservative and cautious about diagnosing bipolar disorder in general, though in our population I did see a few patients with manic symptoms, if not overall full bipolar disorder. If they were not already on a mood stabilizer and there was and their mental status did worsen a little bit, it tended to be that their physical status would get better so they would feel better, and that perhaps increased anxiety a little bit, or perhaps it improved the depression, and then there was a little bit of activation secondary to all of those things. So it tended to decrease the antidepressant a little bit. We then, most importantly, either began or resumed psychotherapy with a substantial psychoeducational component in that therapy. And that therapy was provided by one of our excellent psychologists associated with the program. And in some cases, I did both medication management and psychotherapy. A few sought out psychopharmacology for the first time if they became what I would call activated or perhaps hypomanic. And some of that was that they were also reckoning with increased life expectancy and responsibility. And so then they actually became more hopeful about their lives. And it wasn't, so their decision to seek out psychopharmacology and or psychotherapy was because it was, gee whiz, I'm going to be around a while. I need to get my act together. I'm getting better. And that positive kind of change in life expectancy, quality of life, prompted them to want to optimize all elements of their health care. If present, suicidal thoughts or those tendencies predated modulator therapy. In my patient population, I never thought that they were caused or really increased by the medication. In general, with mood disorders, whether it was depression, manic symptoms, or even let's pull in anxiety, did have some women who wanted to discontinue the psychotropics because they were healthier and were thinking about wanting to conceive and did not want to conceive or be pregnant while taking psychotropic medication. Of the pediatric patients with mood considerations, in general, my impression was that the depressed older adolescents improved with improved CF status. A few parents asked to discontinue medication, and they were parents, though, that were leery or had some reservations about psychotropics even before modulator therapy. There were few appreciable changes in adolescent mental status otherwise. It was also had to work a little bit harder to discern the parental reports about the child's mood and try to then combine that with what the adolescent was telling me and experiencing. Again, the suicidal ideation and or attempts, I found to be pretty consistent before the modulator was started and during modulator treatment, never worse on the modulator. But again, I caution you that this was just the experience from my own practice. Anxiety. I found that to be the most subjective comment about, oh, how are you doing? And you noticed any changes since you started the medication. But I did not hear that immediately after the medication was started. I tended to hear that then 2 and more often 2, 3, 4 months after modulator therapy was started. I also noticed some correlations at the time of day that the anxiety was more noticeable to them was related to the traditional pulmonary treatments, like such as after inhaled medications, after vest treatments. Again, the anxiety responded in many cases to a decrease in the SSRIs if possible. And then again, I'm a big proponent of psychotherapy and also reassurance. Those who expressed the largest increase, or the greatest increase in anxiety, also had comorbidities such as personality traits. I normally stop short of diagnosing flagrant personality disorders, but certainly tendencies. They had a past history of sexual trauma and or intercurrent life stressors. And of my pediatric patients, I had no significant changes or increases in anxiety. Irritability. A few adult patients that had increased irritability were typically ones who were already included in the categories I talked about with anxiety and depressive symptoms, but perhaps that irritability component of the anxiety or depression increased. But again, there was usually an accompanying psychosocial trigger for the irritability independent of the modulator. All were treated with psychotherapy. In fact, most of them were either in regular psychotherapy or were in and out and had that standing recommendation for years, for months, if not years. And some of the discomfort of the irritability actually motivated them to go back or remain in treatment. I did have a few that had treatment augmented with a very low dose of aripiprazole when the irritability had either been longstanding or was associated with a mood disorder that had either an adequate, just barely adequate, or perhaps an inadequate response to an SSRI, or that there might have been concern for a bipolar II picture with not the classic cardinal manic symptoms, but more irritability and activation. Basically, I had no pediatric patients that merited or required changes in psychopharmacology due to irritability. Neurodevelopmental disorders. While there are several patients with neurodevelopmental disorders in my practice group, there were none that I saw since the modulator has been started, it has come out, that had an official diagnosis, or let's say a verified diagnosis of autism. But I also tend often not to think so much in terms of absolute verified official diagnosis, but more of target symptoms. And so with some of these individuals who had neurodevelopmental concerns, I would monitor what are called target symptoms, whether it be increased irritability, increased anxiety, with appropriate behavioral and family work, collaboration with psychology, whether internal to our center or with behavioral therapists in the region, Midwest region. And then whenever I would use pharmacology with anyone, but especially for some of these more vulnerable populations, I would coordinate that very carefully before prescribing, and then at touch points when the patients were prescribed psychotropics, always touch base with pulmonology and the pharmacy team members. Again, what I would like to say, I have the have always had the great privilege of working with some of the highest caliber PharmDs who really know CF and all the medications inside out, and that has really benefited all my patients to have the pharmacists working so well on our team. Now, indeed, I did have worked with several CF patients with body image disturbances, even full eating disorders. If you're going to have an eating disorder, I've always thought that if you're going to have an eating disorder with comorbid medical disorder, the ones that would be the optimal to have, if you're going to select them to have the best eating disorder, so to speak, would be cystic fibrosis and diabetes. And so certainly with cystic fibrosis, there's the possibility for both. I do have several females between the ages of 19 and 35 years of age who expressed an increase in body image, anxiety, and some disordered eating behaviors. However, all were already in psychotherapy and or receiving pharmacotherapy for anxiety disorders, sexual trauma, substance use, and or personality features or personality traits concerns before modulator treatment was started, so that these concerns were well known to the treatment team long before the modulators. They were anticipated by the treatment team and closely monitored, all biological parameters as well as the psychiatric, psychological, behavioral, after prescribing the modulator treatment. Of those, there have been a few that were on some of the CFTR modulators before the triple combination, and they had regularly struggled with the required fat intake. And indeed, our dietitians, nutritionists had worked with them and had come up with maybe the least offensive ways to get the triple modulator in with acceptable fat content. The nutritionists were invaluable in the care of these patients. So I did not experience with my patients the occasion or any instance of where we were surprised or the patients were surprised about body image disturbance or any kind of behaviors consistent with disordered eating after the start of the triple modulator medication. General considerations in the pediatric age group from my practice, you know, the old adage that we always know is that cystic fibrosis is in many ways a family experience, and often the child does as well as the parents do. So certainly this is no exception, that working with the parents and checking in with them is very important. When the child changes, even when the status is for the better, for the health is for the better, then the identities, the roles, the time demands all change for the parents and caregivers. Most do very well with these changes. I used to lament to actually every CF center I've worked in, I've lamented to the team that, hey, may I meet all these folks that are doing so well, which is the vast majority of families. So it's helpful to really identify the families, though, that might struggle with these changes ahead of time. And indeed, those are the ones that I tend to know. So connection with psychology, with family support services, individual therapists for the caregiver can not only be very helpful, it can be crucial. If one, for instance, if a woman, if her basic sense of self, her identity is as a mother, and then if she has 1, 2, or more children with cystic fibrosis, her identity understandably becomes as the best possible caregiver for the child. So that means extra meals, it means medications, it means interfacing with the schools about doctor's appointments, all those kinds of things. And then when all that gets better, and this parent is so thankful that and grateful their child is getting better and is going to have opportunities that that people didn't ever think that they would. At the same time, that changes the parent's role, the parent's duties. It changes how they manage their time, and that needs to be recognized, that even positive change means that the caregivers, the parents who are so grateful and happy with modulator therapy need some support as they reorganize and regroup. Parents of stable, relatively healthy children may struggle with whether or not to start modulator therapy. Am I rocking the boat? My child's really doing all right. Hasn't missed much school. We do the treatments maybe twice a day. Hardly any hospitalizations. We come to clinic every single time they want to see us. Do we want to risk side effects? Do we want more blood draws, want more all of this? And then I have encountered patients or parents being concerned about turning my child into a patient. I want them to have a normal life. I want them to consider themselves healthy people who just kind of coincidentally have cystic fibrosis. I do not want them to identify themselves as a patient. So it's important to recognize some of those concerns, particularly going forward as the recommendations for the triple modulator are going to evolve over time, not just to treat seriously ill individuals, but also to be offered and put into use for other patients who have lesser degrees of illness. Now, if the child has a psychiatric condition at baseline that can benefit from treatment, psychiatric treatment, biological or psychosocial, beginning the triple modulator can provide an opportunity to review the relative benefits or risks or the blessings and burdens of treating the psychiatric condition or concerns along with the cystic fibrosis. What I have been really struck by is that it's given me a wonderful opportunity to work with my patients and have discussions not only about treating pathology or treating problems to get everyone's head above water, and not about treading water even, but I'm able to talk with them for some of the first times about flourishing, really about that. What do you want to do? What do you want for your child? what will make you happy? What kind of dreams do you have? And what do you see yourself doing in 6 months to a year to 5 years from now, when your pulmonary function is improved, when you're able to exercise more, when you're able to go to school and stay in school? I'm having conversations about flourishing. And that is one, I think, one of the biggest changes that I've noticed overall is that I'm able to start setting the table that way. So we're talking about people in treatment whose psychiatric care may be able to be diminished some over time or ramped down some over time. But then we're also talking about people who, with the addition of whether it be psychopharmacology or psychotherapy, who are doing okay, but with those treatment additions can really be happier, more productive, and feel better about themselves, their families, their lives, and they can flourish. And that has been just so exciting. So in summary, my experience as a child and adolescent general psychiatrist who specializes in the treatment of patients with medical illnesses is that rarely, if ever, did I see or was I referred a patient who had the start of psychiatric issues commensurate with beginning the triple modulator therapy. Now, again, I can't say enough, this is my personal one clinician's experience, and it is in a finite, very short window of time. The psychiatric, and that's major psychiatric concerns, okay, so major psychopathology. The psychiatric symptoms that became the focus of attention as I was working, as I do work with patients on the triple modulator, existed before the modulator started, or the individuals had historical considerations that contribute to the clinical picture while on the triple modulator, such as sexual trauma, pre-existing anxiety about appearance, personality disorder traits, or substance use. And I also have always found, but especially with some of the new concerns for individuals that are coming up with modulator treatment, cannot endorse psychotherapy enough. It's invaluable, especially for anxiety related to a new state of improved health. And as some of us would say, the rights and responsibilities thereto appertaining. Had a number of adult patients that were working not only with me, but with their psychotherapists, regular psychotherapists, and with the treatment team about, okay, now you can do X, Y, and Z, and you couldn't before. What does that mean for you? Accompanying that might be concerns about what is insurance, what is workers, what their job situation, disability, those kinds of issues may accompany this as well. And that also, I think, leads into this slide, which is, I cannot say how much I've appreciated the roles and the value of the mental health coordinators to our patients, to our families, to the multidisciplinary mental health teams, and how much I've enjoyed working with them, and it's aided me in my patient care responsibilities as a psychiatrist. Hub of the treatment team wheel and the center of communication with the patients, the families, the medical care providers, multidisciplinary treatment team, both inside the treatment center and then outside to others in the communities in the region that are working with our patients. And As such, the mental health coordinators are often the most aware of patient and family concerns, their vulnerabilities going into the triple modulator experience. And they're also can be the first to pick up on psychiatric changes, and also the people to whom family and the patients feel most comfortable bringing their questions and concerns. And then the next 3 or 4 slides in my slide deck are the references, the most significant references that review some of the topics I've talked about and cystic fibrosis in general. So again, this is my personal experience as one psychiatrist working with a great cystic fibrosis team. And I thank you very much for the opportunity to participate.
Hello, I'm Amy Mueller, co-chair of this session, and I'd like to take about 10 minutes just to wrap up and share a few thoughts on how we might continue today's discussion. First, Dr. Becker and I would like to thank you for attending, and a special thanks to our speakers and conference organizers for ensuring a session for mental health coordinators this year in light of the shift to a virtual platform. We would typically spend a good portion of our time together networking and discussing the topic at hand, but in lieu of that, we encourage you to utilize the chat feature of the session, share your insights and questions on the Psychosocial listserv, or email us and other members of the CF Foundation's Mental Health Advisory Committee for ongoing collaboration. And there's much collaboration to look forward to as we explore many questions emerging from the CF community. We are only less than a year since FDA approval of Trikafta, so what have we observed so far? From our speakers, we heard about the variability of the Trikafta experience, that there are sometimes unintended consequences and impacts on mental health. Major change, no matter how positive, can be stressful, and improved physical health does not always equate with better mental health. The opportunity for longer, healthier lives may bring with it significant practical and emotional challenges. We heard examples of potential cognitive and psychiatric symptoms, as well as the challenge of adjusting to a new state of better health and what that means for one's life and future. We heard about changes to weight and concerns about body image, and know that many people are wondering about what this means for management of CF-related diabetes. And of course, not all are eligible for or wish to start a modulator, may not be able to access it yet, or may experience less than hoped for improvements in health. So these were just some of the issues that our speakers highlighted, but what have you observed? What themes of experience are you hearing as people reflect on their lives, continue to hope for their modulator, or reimagine their futures? How well we listen to our patients' stories will clue us about what they need most and how they are balancing hope with realism in the absence of data about long-term health outcomes. As mental health professionals on our care teams, we hope to learn from each other about how we are guiding patient-provider discussions regarding expectations in this new era, and what mental health issues and practical stressors, both pre-existing and newly emerging, need to be on our radar. We will also learn to what to consider when facilitating the involvement of psychiatry in this process, knowing what potential psychiatric symptoms to be alert to with initiation and early maintenance of modulators, and ensuring our ongoing role in monitoring psychological adjustment and communication across the team. And we have to remember that CF is a disease that affects the entire family system. So how are physical changes impacting and changing family dynamics? And are we inviting families to express their full range of concerns and expectations? How might these expectations inform treatment decisions and impact outcomes? What are we doing to best support families as they navigate this new territory? And finally, in light of COVID-19, what issues do we need to be alert to, both in the short and long term, given the rollout of Trikafta during this pandemic? What are the psychological, emotional adjustments being made while experiencing constraints and improved health simultaneously? Again, We thank you for your interest and your ongoing work with the CF community as we walk this path through a new landscape. Here are a few resources for you and your care teams to consider as we continue this important work. As always, as part of this session, we want to highlight a few professional resources, including the wide array of materials housed in the CF Mental Health Dropbox. And in addition to the listservs, if you're a mental health professional on your care team, please consider joining one of the peer consultation groups. These are standing groups in different time zones across the US that run once a month, offering informal peer discussion on a variety of emerging mental health issues in CF. Please contact Kathy Cooney or Christine Roach if you have questions or to inquire about availability. And lastly, on behalf of the CF Foundation's Mental Health Advisory Committee, we strongly encourage you to email us if you have questions about the work of the committee, any of the resources within the Dropbox, or if you're interested in contributing your time or ideas to projects aimed at advancing mental health care in CF. Here are a few articles authored by committee and community members that you may be interested in. Again, many thanks, and we look forward to hearing from you.